All right, it is noon. And it looks like we have about 50 people on, so I think we will get started. Hello and welcome everyone to our first Lunch and Learn hosted by Foundation for Healthy North Dakota on children's wellness vaccines best practices. I'm happy to see so many people were able to join today. So I'm just going to run through some housekeeping things. The webinar attendees will be automatically muted for the presentation. If you have any questions, please put them in the Q&A box. A recording will be of this presentation. We will be recording this presentation, and we'll leave time in the end to address any questions you may have. After the presentation, a link to the recording will be sent out along with an evaluation survey to complete. So a little bit about us. My name is Mary Lizakowski, and I'm a Coalition Health Director for the Foundation for a Healthy North Dakota. FHND is a newly established nonprofit in North Dakota with a small team. Our mission is to promote health and wellness by working at the community level across North Dakota. We are building a statewide coalition to allow local communities to work together. Coalition members will be first to know about educational opportunities, get the latest on relevant public health information, legislative updates, and access to digital advocacy resources and toolkits. And now I would like to introduce our presenters. Dr. Kathy Anderson is a general pediatrician and integrative medicine physician who has been practicing in Bismarck, North Dakota for the past 10 years at Mid-Dakota Clinic and St. Alexis Medical Center. She has served as chair of the pediatrics at both institutions and has recently launched her pediatric telemedicine practice called Nurturing Wellness Pediatrics. Originally from New York, Dr. Anderson completed her undergraduate and medical studies at Brown University before obtaining residency training in pediatrics through the University of Hawaii. She is board certified. Oh, I lost my track. She is board certified in general pediatrics and integrative medicine. Throughout her career, Dr. Anderson has been committed to the responsibility of serving as an expert in child health and wellness through education and advocacy, in addition to the clinical care she provides. She regularly teaches children, parents, and caregivers, home visitors, colleagues, and legislators about how to keep kids healthy, decrease disease and injury in this population, and optimize health and developmental outcomes for children. Dr. Anderson began her term as president of the North Dakota chapter of the American Academy of Pediatrics in July 2019 after serving as treasurer and vice president for this organization. She is also the regional champion for diversity and inclusion for the American Academy of Pediatrics. She is excited at opportunities for education, advocacy, and partnerships that lie ahead, especially in this time of great uncertainty and need. So thank you again, Dr. Anderson, for joining us today to present on this important topic. And next we have Becky Crane. She is a mom and school teacher who lost her son Blake at age 16 in February 2020 to the flu. She's a parent who has experienced the most severe reality of how serious the flu can be. She now advocates by educating others on the seriousness of the flu and has established on-site school flu clinics in her community with local healthcare provider and school nurses to help prevent others from having the same experience that she had. Becky, thank you for joining us today to share Blake's story. And I'm going to stop sharing. And Dr. Kathy Anderson, if you want to take it from here.
Sounds good. Okay, just bear with me. Can you guys see my screen?
I can.
Yes.
Yes. Okay, look, I'm seeing some hands. Thank you guys. Well, thank you so much for inviting me to present on children's wellness vaccines best practices. I'm really honored, and this is a topic that I am excited to discuss, and I will present I'll go straight through my slides. And then I think there's question answers at the end. So feel free to ask at that time. Here are my credentials. And basically, I am a general pediatrician and integrative medicine physician here in Bismarck. I have no financial disclosures. So, when I go to a lecture, I'm usually wondering why the person in front of me is in front of me. So this is what I think. This is not what the Foundation for a Healthy North Dakota told me, but I think that I'm here because I have a unique perspective. I'm a woman of color. I'm a first-generation American, and I'm an integrative medicine physician. And each of those perspectives add a little bit of insight, experience, maybe connection to vaccines, vaccine preventable diseases, medicine, maybe questions or hesitations around Western medicine that might be different from your typical physician. I have a diverse group of patients. So in my daily practice, I have patients that choose to fully immunize completely on the recommended CDC schedule. I have patients that choose not to immunize at all. And then I have patients that do something in between. So as the child's pediatrician, I counsel, provide information and education to parents as an expert so that they can make informed decisions for their children. I like to increase understanding, and hopefully I do some of that here with you all today. I appreciate being able to understand others through their sharing of stories with me, and also my ability to be understood by my sharing of knowledge and stories with them. So this curiosity to learn and understand extends beyond my academic studies. It really allows me to connect with patients in a way that I think affirms the reason why I went into medicine. And then when I am meeting with patients and families and parents and needing to advise or counsel on difficult decisions, whether it's related to vaccines or outside of the vaccine discussion, I always, I hope that I am always entering a room with respect. And I hope that, that I'm always treated with respect in reverse. And so that we can, work on developing a plan that's in the best interest of the child at the end of that kind of discussion and exam. So why are you guys here? I can't see any of you, but I'm assuming that you're here because you have a child maybe, or your work is related to children or childhood vaccines. Maybe you're interested in learning more about the childhood wellness vaccine schedule, or maybe you're interested in sharing experiences regarding the childhood wellness vaccines. There might be other reasons too, but this is what I'm imagining. This is who I'm imagining that I am talking to right now. So what I hope to achieve during this, this talk is to review the history of vaccines, review the science behind it, review the vaccine preventable childhood immunization schedule, and then the specific vaccines and the diseases, and then propose a framework for understanding disease risk and vaccine risk together. So I'm going to just move you guys over a little bit. So as far as the history of vaccines, basically below I have scientists that laid the groundwork for vaccines, and Edward Jenner in 1796 observed that like milkmaids who had exposure to cowpox didn't really get sick from smallpox, and they were dying from smallpox. And then developed a small experiment where he used some of the tissue from these women to infect a child who hadn't previously been exposed to cowpox or smallpox to see if that provided immunity when he was around people who had the disease, and found that it did. Louis Pasteur did something very similar with rabies. And then Jonas Salk and Albert Sabin developed vaccines for polio, one that is an inactivated or not live vaccine and one that is a live vaccine. So really, I wrote scientific method here as my kind of plug, but the year after the pandemic started, we had our kids doing distance learning, and I had a 6th grader who was learning the scientific method online. And the way that it was being taught, and this is primarily, I think, because of the nature of transitioning to online learning, the way that it was being taught was like super dry. So like definitions of these different scientific processes. But when we look at these examples, really, it started with an observation. And the observation was that people were dying. And so they came up with a hypothesis, they tried the hypothesis out, and then they saw if it worked or it didn't work. So I have to show this, at least this part of the presentation, to my daughter after, because I think those like several months of scientific method in a vacuum were really difficult for her to appreciate or understand. So how do vaccines work? Basically, the body is either exposed to a weakened living pathogen or to a dead pathogen. And that causes the immune cells, which are the little kind of Y cells on this image, to make antibodies to attack the pathogen. And then if the body is again, after that initial exposure, exposed to the pathogen, the body will already have developed an immune response that can respond to the pathogen. Okay, so substitute any disease in here, and we're going to go through a bunch. Vaccine dosing through the lifespan kind of depends on the vaccine, whether it's live or it's dead, and then how long it provides immunity. So some provide greater protection than others. In general, the live ones provide better protection longer term. And then new vaccines are needed to be developed for pathogens, like influenza is a good example, that mutate frequently. So I'm just laying the groundwork now for our discussion so that we can eventually figure out how to develop a framework for weighing risk and benefit. So what types of vaccines are there? There are live attenuated vaccines, and basically this is the weakened pathogen type of vaccine. Usually it requires 1, 2, or sometimes 3 doses. And here are some examples. MMR, varicella, rotavirus are live attenuated. So there's a live component there. Inactivated vaccines contain a killed pathogen. So because they're not live, they don't produce, they don't turn on your immune system as quickly, as much. And so they require booster shots. So hepatitis A is like this, rabies, polio is like this. And then the subunits can contain killed, antigenic, or immune response producing components, and they require several doses or booster shots. And the Haemophilus influenza B, the HPV, and the pneumococcal are like this. And then there are ones that contain an actual toxin that's made by the pathogen. And these also typically require booster shots. And this is like diphtheria and pertussis. So this is a little basis for vaccines and how they're made and what they do to our immune system to protect us. So they're designed to best protect public health, so the health of all of us, and they use a scientific method behind their development and monitoring. So usually the process of vaccine development includes starting with a phase 1, as you can see here, with 20 to 100 healthy volunteers to assess if the vaccine is safe. Does it seem to work? Are there any serious side effects? And how is the dose related to the side effects? In phase 2, there are several hundred volunteers. And what are the most common short-term side effects? How those are discussed, and how are the volunteers' immune systems responding to the vaccine? Sorry, you guys, hold on one second. Sorry about that. I have little people that had a half day today. And then what are the most common short-term side effects and how are the volunteers' immune systems responding to the vaccine? So that's phase 2. In phase 3, hundreds of thousands of volunteers are enrolled. And what we're really looking at is dose response, who gets it, is it safe, what is the effective dosing? So ongoing, even after a vaccine is rolled out and FDA approved, they continue to collect data, review, and then there are ways that we can, if there's any vaccine effect, whether or not it's related to the vaccine, because I mean, I can't necessarily tell that, there's a way of reporting that. So it's sort of ongoing. So now when we're looking at the childhood vaccine development timeline, this sort of lays things out. So for the ones that are currently still being utilized, diphtheria was in 1923, tetanus in 1937, tuberculosis is not used in this country, but it's still being used worldwide from 1927. And then we can kind of walk down this list and you can see when the vaccines that are currently being used within the pediatric population were approved and were developed. And this slide really discusses when what we see as far as change in disease and then percentage decrease in disease, what that looks like as far as like annual, so yearly numbers in the second column, I guess, the specific disease in the first column, and then the cases reported in 2020. And then lastly, the percentage decrease. So when we look here across the board, we can see pretty significant decreases in these diseases. But I think the thing that, I want to ask when I see a chart like this is, well, why is this significant? Like, I can see there's a decrease in diseases, but who cares? I mean, people get sick all the time. Why do we care about this decrease in disease? So what we're going to do next is talk a little bit about vaccine preventable diseases in this childhood immunization schedule through kindergarten. And these are the specific ones we're going to talk about because they're part of the standard immunization schedule. And we're just going to take this time right now to talk about actual disease, how it's transmitted, maybe what we've seen as far as change, and we can revisit that last slide that I just showed you as well. So we're going to start with rotavirus. Most people, I think, are aware of what rotavirus is. It causes a vomiting and diarrheal illness. Pre-vaccine, lots of kids got hospitalized for rotavirus for dehydration. In the developing world, it is also a pretty significant cause of death because of dehydration related to lack of access to care primarily. So when we think about transmission for rotavirus, it's fecal oral, which just means like anything you put in your mouth can transmit rotavirus if rotavirus is on your hands. So especially for little ones who, aren't able to not put everything in their mouth, they're at high risk. And definitely we do see this vaccine preventable disease a fair amount if a population is not getting vaccine. Thankfully, in this country, it doesn't usually lead to death because of access to care. But pre-vaccine, we were seeing about 500,000 diarrheal dehydration deaths worldwide. So for diphtheria, you don't hear people talk about diphtheria, like it's part of the DTaP, it's part of the TDAP, but nobody really talks about it. I don't think we remember as a community what diphtheria is. So basically, it lives in the nasopharynx, and it is communicable, so you can catch it from other people. It's transmitted through respiratory droplets, and it's an aerobic gram-positive bacillus. It does produce toxins, and those toxins inhibit protein synthesis within your throat. So it causes like a sloughing of the inner part of the throat, and that makes it very difficult to breathe. The swelling can make the throat close up, or it also, when you're trying to intubate with diphtheria, it's very, very difficult because the tissue just sort of falls apart. So some of the major complications are that it can cause myocarditis, which is an inflammation of the heart muscle. It can cause nerve issues, kidney issues. And, because of what I described, the mortality rate is 5 to 10%. So in the 1920s, we were seeing 100 to 200,000 cases a year with 13 to 15,000 deaths. And between 96 and 2018, there were 14 cases and 1 death. So with 3 doses of the diphtheria component of the vaccine, it provides about 95% immunity. So the next one is tetanus, basically, we're going to talk about. So this is a spore-forming gram-positive rod. Basically, these descriptions, they are just what we see when we look at it underneath the microscope. This one's not communicable, meaning you don't catch it from another person. It's transmitted usually through puncture wounds. So you think about like stepping on an old dirty nail, and then spores from like soil and excrement enter the body through that. And it's anaerobic, meaning it likes to grow without oxygen. So it binds to different points at where the nerves and the muscles connect. And that's what causes this sort of like spastic paralysis. And so it causes these really violent muscular contractions. It can make your blood pressure go up. It can make contractions in your airway. It can actually break your bones because your muscles are contracting so much. And we saw like 500 to 600 cases a year before the vaccine. And in 2018, there were 23 cases and no deaths. The mortality rate is 2.5 per 100,000 in 1900, and now it's approaching 0. I'm sorry, you guys, for the interruptions. Let me just let my kids know. All right, let's go to the next one. So Bordetella pertussis bacteria. You guys have heard of pertussis. It is regularly circulating within our community. It's a gram-negative bacterium. It's toxin mediated, and it's transmitted through respiratory droplets. It is very easy to catch. When we look at this little boy, we see bruising around his eyes. We see bleeding within his eyes from forceful coughing, and he really doesn't look well. This is highly communicable. It's easy to catch. It's in respiratory droplets. It attaches to the respiratory cells within the throat and throughout the respiratory system, and then it increases secretions. So before vaccines, it was one of the most common diseases and causes of mortality in children. And before the vaccine, it was about 175,000 per year with about 10,000 deaths. Infants are at especially high risk of this. It can cause bacterial pneumonia, it can cause seizures, it can cause them to stop breathing because of such forceful coughing. And then bacterial meningitis. So these 2 vaccines protect against bacterial meningitis, and I'll talk specifically about each of them. But basically, the meninges are a layer around your brain within your skull. And meningitis is inflammation of that layer. Now you can get viral meningitis from like enterovirus is a common one, or you can get bacterial meningitis. With bacterial meningitis, children, adolescents, adults, college students can get very, very sick. It causes the brain to swell. And after a certain point of swelling, the brain can be forced to go down or herniate down the back of the neck. So this is a very, like meningitis, whenever you hear it, especially bacterial meningitis, is a very serious infection. Children under a year of age are at higher risk of meningitis because the blood-brain barrier is leakier. So that just means like we have bacteria that circulate through our body and our body clears on a regular basis, and it can circulate through our bloodstream and our body clears it. But because of that, for babies especially, the risk of them getting meningitis is greater because of that leakiness between the blood and the brain barrier. So for Haemophilus influenza B, this is a gram-negative coccobacillus. It's in the nose. It's transmitted through respiratory droplets or through direct contact through the birth tract or amniotic fluid. It's limited as far as how you get it from other people, but it's something that we are colonized with. So bacteria lives on our body, on our skin, in our nose, in our mouth all the time. But this is one that caused significant illness in children. You'll hear like older pediatricians. I don't know if any of you guys know Dr. McDonough, but older pediatricians will talk about how often they had to do spinal taps and how often they saw meningitis, active meningitis in children prior to the development of this vaccine specifically. So it's the leading cause of meningitis in children under 5 years of age. So 2/3 of children with invasive Haemophilus influenza B had meningitis. So there's something about it that likes to go to that tissue, something about the organism. Disease sequelae, so just like what happens when you get Haemophilus influenza B, you can have permanent hearing impairment, and that's pretty much with any type of bacterial meningitis, mental retardation, cognitive or developmental delay, paralysis, and then it can infect your blood, your meninges, your epiglottis, the little thing hanging in your throat, can cause pneumonia in your lungs, can affect the tissue around your heart, and it can get into your bones. There's a 4% mortality rate with Haemophilus influenza B infections. So it was about 20,000 cases per year before the vaccine. And then in 2009 to 2018, so how many years is that? 9 years, there were 36 cases. So reduced to about 4 cases per year in the US after vaccine. Okay, and then this is pneumococcal. So another one that can cause meningitis, can cause pneumonia, and can cause ear infections. And I'm only talking about childhood vaccines today, but this is also the pneumonia vaccine that's given to older adults. So what we can see in this left purple one is that for those who get it, the pneumococcal meningitis kills about 1 in 12. And for children, and 1 in 6 for adults. So the goal really, I mean, that's a pretty high percentage, like more than probably 15, 17% of adults that get it, and then a little under 10% of children who get it. This other diagram over here looks at the rate of invasive pneumococcal disease in children under 5 between 1998 and 2015. And you can see how that has kind of dropped with the vaccination over that time period. And then this is hepatitis A. This is typically given at 12 months and 18 months of age. It's an RNA virus. It's transmitted fecal oral, so just dirty hands. It's usually seen in outbreaks that occur more often in the summertime. I think there was one in San Diego maybe last year. And the virus is present in the blood and in the stool. It can cause fever, nausea, like abdominal discomfort, dark urine, jaundice. And the largest outbreak this pre-vaccine was in 1971 with about 60,000 people. And then across the years of 2016 to 2021, there were 37,000 individuals infected. So it's more symptomatic disease and liver shutdown in older children and adults, and usually more asymptomatic disease in children. Hepatitis B is another virus that infects the liver, causes damage to the liver cells, but it's not transmitted the same way as hepatitis A. This one's typically given, it can be given at birth, and then it's given within the first 6 months of life, generally, the 3 immunizations over that time period. And it's transmitted through blood products. It can be transmitted through both blood and mucosal surfaces through childbirth. And it progresses to chronic disease. Its progression to chronic disease depends on age. So really, for any pregnant woman, I would say there is absolutely no reason to refuse a test for hepatitis B, just because disease transmission can be really high, just going through the birth canal, and because there's not good treatment for hepatitis B. And then there are things that we can do for baby to prevent that transmission of disease. And then lastly, because diseases contracted in infancy leads to progression 90% of the time in infants, 30 to 50% of the time in 1 to 5 year olds, and then 5% of the time in adults. So if you get hepatitis B as an infant, you are going to have chronic disease 9 out of 10 times. And then if you're an adult that contracts it 5% of the time. So 25% of children with hepatitis B virus infection and 15% of adults will die prematurely. So this is polio virus. It is a RNA virus, and you get it, kind of fecal oral or oral. That's how it's transmitted. It infects and destroys cells in the nervous system. And that's why, because it's affecting the motor neurons, it can cause paralysis. So 70% of polio infection is asymptomatic. That means you don't know you have it. You feel just fine. You're not taking any additional precautions to not spread it because you don't have any symptoms. 24% have mild fever and sore throat. 1 to 5% will have an aseptic meningitis. That's just what we call it when it's viral, not bacterial meningitis. So they'll have like headache, vomiting, neck pain, maybe sensitivity to light. And 1% of polio infections, usually in children, can lead to a flaccid paralysis. So in 1988, polio paralyzed about 350,000 people in 125 countries that year. Most were not in the US, because the US was considered eradicated of polio in 1979 until August of this year, where there was a case of paralytic polio in New York. And so, the big concern with that is it takes about 100,000 cases of all these other polios in order to get one case of paralytic polio. So when they started looking at the sewage system, which for a fecal oral transmitted infection is a great measure, in New York and also in London, they're finding that polio is there. So this is really concerning when we think about like these images over here of children. I even had a patient tell me that her father had paralysis related to polio. So I think, although this disease is probably pretty distant for most of us living in this country, it is a disease that even historically, one of our presidents had paralytic polio. So historically, it is part of our memory. And I would say, like personally, the reason that I went into pediatrics was not because I wanted to be a doctor. It was just because I wanted to decrease suffering. And the images of suffering that I had as a child really came from my travels to visit family outside of this country. And I didn't understand why there were children who were disabled on the streets begging for money in Indonesia, where my mom is from, when I was growing up. And, you know, learning all of this information and understanding that some of these diseases, some of this suffering could be prevented is really kind of why I'm doing this. And I hope that I'm educating you all on this, but I can tell you outside of this country, this is a very real disease and one that you can see the effects of on a regular basis. Okay, so measles is an RNA virus. It's respiratory transmission. So it is communicable, very easy to catch actually. It can cause ear infections, pneumonia, encephalitis, which is kind of like a brain effect. And it can also cause death. Before the vaccine, there was roughly 500,000 infections a year with about 500 people that died. And the decrease in infections have been about 95% after the vaccine was developed. In 2019, there were 13 outbreaks that had 663 cases that they believed were clustered in under-immunized communities. And I'll kind of explain to you what we mean by under-immunized moving forward. Here's mumps. Mumps is also an RNA virus. It's also transmitted through respiratory secretion. So anything that's respiratory, if you're breathing, you're talking, you're coughing, it's easy to spread. It can cause like inflammation of the testicles, of the ovaries. It can cause kind of classically what you see in this picture, the parotid gland. It can cause mastitis of the breast, meningitis, inflammation of the pancreas, and hearing loss. There were 152,000 cases in 1968, and in 1985, fewer than 3,000 cases. Rubella is an RNA virus as well, transmitted through respiratory droplets. It can also be transmitted transplacentally. And rubella is one of the congenital infections passed from mom to children that can be quite devastating. It can like pause development of growth of the head and brain. It can affect the heart's development and cause congenital cardiac disease, and then it can affect the eyes. It can also cause stillbirth. And then this is chickenpox. I'm assuming most of you on this call probably had chickenpox yourself. I had chickenpox as a child. It's transmitted through respiratory tract, through the eyes, and then also through the fluid in these little bubbles. And really, the older you get, the worse this infection is. More kind of serious complications of pneumonia and central nervous system infections. And then we've seen a decline in these infections, 97% since the vaccine. It can also be a really serious infection if you contract it when you're pregnant. So basically, vaccines protect those that are vaccinated, but they also help to protect all the people that you live around. But that only works when a certain amount of the population is immune to a specific disease. So the amount of protection that you need the general population to have depends on the disease itself, the vaccine itself, and the mode of disease transmission. So when no one is immunized, the disease spreads through the population and lots of people get sick. If the effect of them getting sick is they don't feel good for 2 or 3 days and then they're better, then nobody is going to spend their time or money looking for a way to improve the situation. So when some of the population is immunized, it spreads through the population. And when most of the population is immunized, then the disease spread is more limited. So this is kind of a concept of herd immunity. When a large portion of the community becomes immune to the disease, whether it's by immunization or by getting the disease, then the whole community becomes protected. Basically, the stakes are, how bad does it get when you have the disease, right? So if herd immunity is developed naturally, that's fine, as long as the risk of getting the disease is not crazy as far as like mortality or disability. So when we look at this, basically for these diseases, and these examples are limited by my ability to find the herd immunity threshold, not anything else. Also, if it's not a communicable disease like tetanus, it's not going to be on here because it really doesn't matter how much is in the community because we're not sharing it between each other. So basically the herd immunity threshold, and this is the North Dakota vaccination threshold in kids between 18 months and 3 years old, in the third quarter of this year. So this is kind of a flash. This is not total population, just because I don't have that data. But what we're seeing here, basically, in order for us as a community to be protected of these diseases, we need this number over here to be higher than this number. And maybe we're in range for mumps. And polio has a wide range. Maybe we're in range for polio, but for everything else, we're not in range. So what this means when we look at this chart is we can't use recent past to predict future as it relates to vaccines. There have been kind of several discussions in different media on what this means for us. Kind of short-term and long-term. So how do we weigh disease risk and vaccine risk? This is like the question, right? And every day when I mean, most of the time I'm not giving lectures, I'm seeing patients and families. And when I have any patient, I discuss with them kind of what I discussed with you as far as the diseases. And then I talk about the vaccines themselves and then the reactions and responses that we see with the vaccines. And I think the most important thing to weigh is the risk of disease against the risk of vaccine reaction. And that weight should be related to number, but it should also be related to severity. So in my mind, if a disease could cause meningitis, where there could be severe neurologic devastation or death, and there's so much randomness around, like we're all colonized by these bacteria, and there's randomness around who develops it, is that a risk that I, as a mother, would be comfortable taking for my child? And I'm not making that decision for my families. They're making this decision themselves, but it doesn't sit well with me. It's a high stakes kind of risk benefit. So in closing, the big question is, how do we work together to keep our children safe and our children and ourselves safe from suffering? And really the question for me is, how do we work together to keep all children safe and all children and families safe from suffering? Thank you guys so much for having me here. I hope I didn't go over too long, and I will be happy to take questions at the end.
Thank you. Right. So thank you so much, Dr. Kathy Anderson. In the interest of time, I think we will move to Becky Crane so she can share her story. I'm gonna share my screen. Can everyone see this?
Yes. Yep.
All right. All right, Becky. So I will start with the video for her story. All right, Becky, can you see the slide? Oh, Becky, we don't hear you right now. Are you on?
Hey Mary, it's Shelley. I'm not seeing Becky on right now, so I'm assuming some technical difficulties on her end. I don't know if you want to give it a couple minutes.
Sure. I can kind of start reading her slide too. And when she hops on, she can take over too. Hannah, did you have any contact with her?
I have not heard from her at all. So, yeah, I would say if she's not on, and I'm not sure when she dropped off either, maybe she experienced a technical difficulty. But I think we should probably just go ahead and proceed to the end slide, and maybe we can reconnect with her for a different webinar.
That's good. Let me see. Just gonna see if she was there. Okay. So we will have we'll have her join back at a different time to share her story because it's more impactful from her. And so we will close this out. With answering any questions that anyone may have. I see some hands raised. So let's see here. Anything in the Q&A? Oh, and so let's maybe move to any questions, and then if it looks like she is trying to join back on, and if she does, we can finish up the story. Let's see. So, Paulette, did you have a question? I see you raised your hand.
Oh, sorry. No, I do not. Thank you.
Okay. Dorothy, did you have a question? I saw you raised your hand.
No, that
Okay.
was when you asked if we were here.
Oh, okay. Thank you. Well, we can cover while Becky is trying to connect, we can
Hi, Mary. I'm happy to take any questions if you guys would like to write it in the Q&A. I'm sorry that I kind of rushed through. I feel like it's so important to like understand disease as well. And obviously the disease is interesting to me. I hope I was able to get it across in a way that was easy for our audience to absorb. And if there's any questions, I'm happy to help to answer.
Dr. Anderson, I'll ask you a question, just something that has come about in discussions that I've had with some friends and family. What are your recommendations when you get families that inquire about spreading the vaccines out more, as opposed to what's recommended in the vaccine schedule?
Thanks for that question, Shelley. So I get this question a lot, multiple times a day. And in general, I recommend the recommended schedule because that has been the most studied. And it doesn't, basically the risk of delaying a vaccine is that you're delaying protection for the disease. And as someone who has had the privilege or misfortune of caring for children with the diseases, in my mind, there is not a question. But I basically work with families to make sure that they understand disease risk as well as immunization risk, and then that they're comfortable taking on the risk that they choose. And then I couple that with a discussion of the child's risk based off of their age. So, like I said, with meningitis, for a child under a year, their risk of meningitis is higher. And a bacterial meningitis can be very devastating, even if the child lives. And so that's a pretty high stakes risk, I think. But it's one that I want to make sure the parents are using to make their decisions. So really, it's an informed discussion of vaccine and infection and risk that I have with a lot of families.
I just have a comment. I liked your the vaccine dosing through the lifespan slide, because I don't think people always realize why is a yearly vaccination needed versus for such as flu versus just why some are lifelong immunity, because sometimes we get those people who are like, oh, I need to have another flu shot, but it's so important. So I like that you touched on that.
Thanks, Mary. I wish that we incorporated more science education into our curriculum at an earlier age, because kids are they're like sponges for learning, but they are also so in touch with, with everything, with butterflies, developing out of cocoons, and with chicks being born, like all of these things are science. And I think if we spent just a little bit more time doing science, and you can learn language through science, you can learn math through science. Obviously, I'm biased, but I think it would really, really help us remember, understand, have knowledge to attach these things onto. That would make some conversations a little bit easier to communicate with the same basis of knowledge.
Yeah. All right. So I do see that Becky is on. Becky, can you?
I'm here, yes.
You're here. Okay.
So sorry, I don't know what's going on.
Let me go back to the beginning of your slides quick. And so we showed the video, and so this is kind of where you were going to begin.
Okay, I'll just go ahead and share what I can till I get kicked off again. So sorry about the technological issues I'm having, but I'm honored to be here as Blake's mom and share our experience in hopes that other people can learn the lessons that we had to learn the hard way. Hopefully you saw in the video, Blake was a healthy kid, just a normal 16-year-old teenager. He played the trumpet in the band, and he was a pitcher and a first baseman in baseball. So he was healthy. He started getting sick on February 14th, Friday. It was an early release day of school. He had come home, just at the end of the day. It was about 1 o'clock by the time he got home. And he started complaining of starting to not feel great. The flu had been running around, going around town. I knew people that had been out of work for a week, the week prior, but still, I just thought, what a bummer. He's catching it. We decided to go ahead on a trip that we had planned for the weekend. He had received a gift from his grandparents for Christmas a couple months before, to take him snowboarding, because he was the only one in our family that went snowboarding. So it was kind of a weird thing. So we hit the road, and we went to a motel 5 hours to the south of us. He slept the entire way on that day, February 14th, but no worries. He was 16 and that was pretty typical, and he wasn't feeling great. We were sharing a motel room. The next morning he woke up and he started complaining of a severe sore throat. And we were actually in hopes that maybe he had strep, and antibiotics could help, and maybe we could get a day of our weekend back. So we made an appointment at an urgent care in the city we were in. Was not our hometown, and went there about 1 o'clock in the afternoon on Saturday. And we were there for about an hour. He told them about his sore throat, and they tested him for strep, waited for the results. And at the end, the doctor came in and said, well, you don't have strep, but so the good news and bad news. Good news, no strep. Bad news, no snowboarding. You just have a virus, and you need to take him home and put him to bed and make sure he's drinking lots of fluids. And that was that. So that's exactly what we did. We took him back to the motel, and he was taking NyQuil and fluids and such. And we left for a bit and went out to eat. And by the time I got back, he had developed a cough that he hadn't had earlier in the day. And then even later that evening, he started complaining of back pain, upper back pain. And I remember thinking he must have pulled a muscle or something from his cough that he was doing, or just achy from the flu. We had him take a hot shower, stuff like that. Next morning, or in the middle of the night, the cough was pretty icky. It had progressed, but so the next morning we decided, to call this weekend over, and headed home. Sunday morning left, got home Sunday afternoon, and he, walked himself from the car up to his bed, and my husband kept checking on him, and eventually that evening, Sunday evening, he started vomiting blood. And that's when we decided to take him back to the hospital. On the way to the hospital, I remember just thinking that the worst case scenario in my mind of somebody that's had the flu for a couple of days was pneumonia. I knew that, virus, my understanding was that viruses could settle in the lungs after a long period of time and cause pneumonia. And I was racking my brain thinking, what is this? What is going on? When we got to the hospital, he walked himself in on my arm, just, and then they got us right in. Thankfully, soon as we were sitting in the intake room, they were trying to take his oxygen rating off his finger, and they were struggling to do so. And about the same time, they noticed that his coloring was draining from his face, and his lips were turning purple, and things got, frenzied fast at that point, and realized he was in respiratory distress, and took him back. And of course, from there, I was in shock, and it went fast, and they were trying to transport him to another hospital. the first thing they told us is they found that his lungs were full of blood. And I just remember saying, I don't know what that means. Like, tell me what, I don't know what this means. And then wasn't too long after that, a flu results came back from a flu test, and they told us he had influenza B. And I again remember thinking, I don't know what that means. That must be a rare strain of the flu. I don't understand this. As they were trying to stabilize him, to get him, to transport him, they called us into a side room like they do in the movies, and the emergency room doctor came back, and she told us that they didn't expect him to make it. He was already in multi-organ failure. And in that same conversation, she asked me if he had been vaccinated for the flu that year, and I had to say no. And I made the connection very clearly that had I said yes, I probably wouldn't be here. And that was tough. I felt very responsible for his death. It took a lot of processing over the years, over time, and to be able to work through that. The truth is that Blake had been vaccinated every year of his life. I was a rule follower. I took him for his regular visits to the doctor, annual visits to his pediatrician, and when they suggested he get a flu vaccination, we did it. More often than not, we were there in August for sports physicals, and had to come back a couple months later. That year, Blake had started driving on his own, and getting him to the doctor's office after school was just not as convenient as it once had been. So because he was, driving himself and not just in my car, and I couldn't just get him there. So we missed it. And like I said, I carried that with me, well, of course I still do. As they tried to transport him or transfer him over to the equipment of the transporting team to the new hospital, they lost stability, and Blake ended up dying of cardiac arrest at 2 a.m. on the early in February 20th. So he had just been sick for 2 days. And it went fast. I knew instantly that our family had been through, struggles before. And I knew that one of the most important things was I needed to make sure that I communicated I talked to others about this. And I already felt like I was to blame. And I already felt like I was going to carry a big shame if I didn't continue to share his experience. I wanted to be open and honest about what happened, rather than hold it as a deep, dark secret and let it ruin me as well. So I knew then that I was going to share Blake's story as often as I could. And I didn't know about families fighting flu or anything like that. But I soon, I spent my evenings, my nights, my sleepless nights, desperately searching for more stories like ours. And because it made no sense. I remember hearing just a day or two after Blake had died that somebody had a child at home that had just been tested positive for influenza B. And I thought, how can that be? Why aren't they at home with that child? Why are, it was, I really thought that influenza B must kill everyone, I thought it was a rare strain. When we decided that we wanted to do school-based flu clinics in our schools. I'm a teacher. You may have noticed I'm a teacher in the same school district that Blake grew up in, and Blake was a junior in high school. And I've taught here for 23 years and know a lot of people in the community and such. So when I reached out and to see if we could make this work, flu clinics in the schools, I got a lot of yeses, which was wonderful. A lot of people supporting us, and it's been great. We have a community-based wellness center that was able to step up and provide us the bus and the nurses, the shots, the injections, and the staff to run it for 5 days of flu clinics in our school district for the last 3 years. So prior to that, we had not had, staff members got flu shots for free from our school nurses, but students did not. So we've had our battles with bringing the bus and the clinics to our schools. Especially noteworthy was last year with vaccine protesters at each of the clinics, saying horrible things and just making it not as positive as it should be. And I'm glad to report that they weren't there this year. We're continuing to make it better and better. We're continuing to work on the partnership that we have between the school district and the community-based wellness center, because there are some definite obstacles in trying to follow rules from both sides. But my goal was simply to provide more convenience for the families in our community to be able to get their children their flu shots each year, because I know that had that been the case when Blake was alive, that last year he would have had his flu shot, and I wouldn't be sharing this story. I like to mention also that I was able to speak to the doctor at the emergency room urgent care the day before that he died, and I was able to speak with him after Blake's death. And we don't blame him, but we do wish, of course, that that visit had been different. And I now know that it's important to test. He got a strep test, but had he had a flu test, just might have been a little different. Had I been given some warning signs of what to look for in respiratory distress, that might have been changed things. I was pretty clueless, unfortunately. Even as an educated woman, I always knew that I wasn't a good nurse. I always had people in my life that could help me, with simple diagnosis or what next, because it was so hard for me to ever tell whether, are the kids faking it, or are they really sick? I always had a school nurse, a text or a phone call away. But in this case, I mistook Blake's complaints of not being able to breathe, even as simply like his nose. I thought he meant his nose was congested. His sinuses were congested. I didn't realize he meant that his lungs were full and he was truly having a hard time breathing. And it just didn't click. And over time, I've been able to accept that had I known, I would have done things differently. And while I made mistakes, we could have probably got him to the hospital sooner and maybe made a difference. I know that it was simply because we didn't know. And so we move on in life with that knowledge and just try to share our experience so that others can learn from it. I think that's the rest of my story. These are just pictures of the flu clinic. There's my husband visiting a flu clinic, and with Blake's picture there, taking a moment. It's been notice the balloons and stuff, and we're right outside our schools. There's the big bus is right outside the schools, and they've been very well received. And we give, I don't know exact numbers right now, but a couple hundred shots a year. So Are there any questions, or I don't know. how
And
you-
here's one last photo.
Yeah. This is me, since you can't see me today. There is me in the bottom right with my students. That's this year's flu clinic. So when they came to my school, I took the students that were signed up from my classroom, and we all went out together and got our shots. And right above that is my school principal getting his with his daughter on the bus. And then to the far left is our school superintendent. She wanted to be the first one to get her shot and share that out as to show her support, because she's brand new to our district this year. And I honestly had to present this story to her over the summer and say, this is what we've been doing. Are you still going to let us do it? And thankfully she did. So. This is a lot of the stuff that we provide both on social media. We've done some advertising, as well as we have posters that our nurses hang and keep. We have postcards with Blake's story on it that we pass out not only in our schools, but I leave them at pharmacies and doctors' offices and such. And I loved how Families Fighting Flu let me pick what materials we used according to what message I wanted to be most strong. And so definitely, like the postcards that we have had made with Blake's story on them, the other side discusses or shares the signs of respiratory distress, because those would have been important to me.
Thank you, Becky, for sharing Blake's story. Yeah, it's so touching, and I love the way you were able to lead and bring the community together and provide flu vaccinations in the school and honor Blake in that way. So thank you so much for being here to share.
Thank you for having me.
So I'm just going to end here by thanking everyone for attending the presentation. To stay connected with us, you can follow Healthy NODAC on Facebook, Instagram, and Twitter, and Foundation for Healthy North Dakota on LinkedIn. Also, to join the coalition, visit the link to stay aware of future webinars and updates on the foundation. And lastly, please scan the QR code to complete the evaluation of the survey if you're able to. We will also include a link to the survey in our follow-up email after the presentation. So I appreciate everyone for joining and staying a little bit later. And I hope everyone has a good rest of your day.